Welcome to the Deep Dive. This is where we aim to give you those vital insights, especially when the pressure's on. Like if you're an orthopedic resident facing your postgraduate exit exams, the FRCS or maybe similar fellowships, and, femoral neck fractures, they're high yield, definitely, but often pretty complex.
That's true.
So today, we're diving deep into just that, our mission. Really unpack the complexities, highlight the key evidence, and, aim for those aha moments. Things that will give you the confidence and the knowledge you need for the exams, sure, but also just for your future practice.
Absolutely.
And this whole deep dive, it's based on the brilliant Ortho Made Simple notes you can find on mokyingren.sg. They were put together by Dr. Mok Ying Ren. He's a sports surgeon over at National University Hospital in Singapore, and he got his FRCS back in 2022.
Yeah, great resource. And look, to really get a handle on femoral neck fractures, you have to start with the basics, the foundation.
The anatomy.
Exactly. The anatomy of the proximal femur. It's not, just a simple bone structure. It's actually quite intricate, designed with 5 specific trabecular groups.
Right, 5 groups.
And these groups are not just there for show. They all converge, and where they meet up, that's Ward's triangle.
Ward's triangle, right. I remember that.
And what's really interesting is that this triangle, it's an area of inherent weakness, sort of a natural stress riser.
Ah.
And that's exactly why fractures often propagate right through that area. So understanding this immediately gives you that anatomical why these fractures happen where they do.
That's a really critical point to start with.
Yeah.
So how does that anatomical insight, the trabecular groups and Ward's triangle, how does that translate into something practical we use, like Garden's alignment index?
Right.
We hear that term all the time, but connecting it back like this makes it clear, doesn't it?
It does, exactly. Garden's alignment index is basically a visual check of that alignment we're talking about. It measures the angle between those main compression trabecular lines in the femoral neck and the long axis of the femur.
Got it.
So for good alignment, say in a healthy undisplaced fracture, you're looking for an angle between 155 and 180 degrees on the AP view.
155 to 180 on AP.
And on the lateral view, it should be straight. 180 degrees. It's a quick visual check, tells you loads about the displacement.
Okay, that makes sense. So with that anatomical base set, let's shift gears a bit. Let's talk about managing hip fractures in the elderly. That's a huge part of orthopedics.
Huge.
What are the absolute first steps, the immediate things we need to do even before we think about the OR?
Right. For older patients, the key is really a multidisciplinary team approach, an MDT.
Involving geriatrics.
Absolutely, from day one, because you're managing the whole patient, not, just the broken bone.
Right.
So immediate care, 2 big things. First, good pain management. And you should really consider nerve blocks here. They can be a game changer for comfort and maybe reduce opioid need.
Good point. Nerve blocks.
And second, DVT prophylaxis, deep vein thrombosis. That's non-negotiable.
Okay. What's the standard protocol there?
Well, following the NICE guidelines, the 2018 ones, typically it involves low molecular weight heparin, like Clexane, usually 12 hours before surgery, 12 hours after, and then continued for a whole month.
A full month. Wow.
Yeah. Along with mechanical things like calf pumps, these early steps really do impact the overall outcome.
That's crucial background care. Now, here's a topic that always generates discussion. The timing of the surgery.
Yes.
How soon is soon enough? What's the evidence say about the urgency? Is it just about hospital flow, or is there more to it?
Oh, it's much more than just logistics. The data is, pretty overwhelming in supporting early surgery.
Okay.
There was a huge meta-analysis, Lorenzo and colleagues, 2012, looked at something like 190,000 patients.
Wow.
And it showed surgery ideally needs to happen in under 48 hours.
Under 48 hours.
Yeah. And this isn't just about, efficiency. It's about changing the patient's whole systemic response to the injury. Early surgery is consistently linked to a lower risk of death and fewer really bad complications, like pressure sores.
Okay, that's significant.
And it's backed up by other data, too.
Yeah.
The U.S. National Trauma Data Bank, for example. They found surgery after 48 hours doubled twice the odds of increased mortality and major complications. Things like ARDS, heart attack, pneumonia, severe sepsis, or needing the ICU.
Twice the odds. That's huge.
It is. The aha moment here is realizing that delaying surgery basically turns this local fracture into a whole body systemic crisis. It really is a race against time, not just for the bone, but for the patient.
That's incredibly sobering, especially when you think about the mortality rates already associated with these fractures.
They are high, yeah. It's a stark reminder of just how much systemic impact these injuries have on older people.
What's other specific figures?
Well, a local Singapore study, for instance, reported something like 5.7% mortality just during the initial hospital stay.
Just in the hospital.
Yeah. And then, wait for it, 26% mortality within 1 year.
A quarter of patients within a year. That really hits home.
It absolutely does. Which brings us back to the urgency, right? The NICE guidelines specifically say surgery within 24 hours if possible.
24 hours. Okay. That's the target.
And that's the ideal target to try and cut down those risks.
Okay, so we've covered optimizing the initial care. We understand the urgency. Let's dive into a specific scenario. An undisplaced femoral neck fracture in an elderly patient. This is a big decision point, isn't it?
It really is.
To fix it or to replace it?
Mm.
What's the evidence telling us for an undisplaced injury in this group?
Right. So for an undisplaced fracture, if the patient is, say, under 80 years old, fixation is generally the preferred route.
Fixation under 80.
Yeah. There's a pretty solid retrospective analysis. Martin Parker and colleagues back in 2008 looked at hundreds of patients.
Okay.
They found fixation meant shorter surgery time, shorter hospital stay, fewer complications, and actually lower 1-year mortality.
That sounds pretty convincing for fixation.
It is. The potential downside, maybe, was a slightly higher chance of needing another operation later, reoperation. But overall, the benefits seemed clear in that group.
But what about the very elderly, the super-aged, as you called them?
Right, good distinction. For patients over 80, some studies, like an RCT by Keifeng and colleagues, suggest that maybe replacement could lead to fewer post-op complications, fewer reoperations, and maybe even better functional recovery.
Interesting. So it's nuanced by age.
Very much so. You have to consider the individual patient's physiology and age.
Okay. So if you do decide to fix an undisplaced fracture, what about the device? You hear about screws, maybe other implants. Does the evidence favor one over the other? Especially when some reviews say there's no big difference.
That's a good question. It's true. A lot of systematic reviews will broadly say no significant difference between the common implants for undisplaced fractures.
Right.
But, sometimes you need to dig a bit deeper, look at specific fracture types.
Like the Paulo classification.
Exactly. Take the Frank Liperace study, JBJS 2008. They looked specifically at Paul type 3 fractures, those really vertical ones.
Okay.
And they reported a non-union rate of 19% if they used cancellous screws versus only 8% if they used fixed angle devices like a DHS or similar.
So less than half the non-union rate with a fixed angle device in those specific fractures.
Right. Now, importantly, in that particular study, the difference wasn't statistically significant, maybe due to numbers, but it strongly suggests, doesn't it, that for those high shear vertical fractures, a fixed angle device might just offer more stability.
That makes biomechanical sense.
It does. So while the big picture might say they're similar, understanding the fracture pattern itself can definitely nudge your choice.
That's a great example of looking beyond the headlines of the evidence. Okay, let's shift to maybe the more common or at least more challenging scenario. An old, displaced femoral neck fracture.
Right. The game changes here.
For most of us, the first thought is AVN, right? A vascular necrosis. How does that high risk steer the decision-making?
You've hit the nail on the head. With a displaced fracture in an elderly patient, the risk of AVN and non-union is just so high.
That fixation is usually off the table.
Pretty much. Replacement becomes the standard, almost universally indicated approach. Trying to fix it just carries too high a failure rate in this group.
Okay, so replacement it is. Then the next big question comes up. Hemiarthroplasty or total hip arthroplasty. Hemi or THR.
Yeah, another critical decision point.
What's the evidence telling us now? Because I feel like this has evolved a bit over the years.
It really has. Traditionally, NICE guidelines would look at things like how well the patient walked before the fracture, other health problems, their mental state.
Right, and THR was often for the fitter, more active ones.
That was the classic thinking. But recent large studies are really challenging that.
Like what?
Well, take the HOPEAT trial from Sweden. It was an RCT, looked at 120 octogenarians, people in their 80s.
Okay.
And it found no significant difference in their outcomes or hip function between Hemi and THR at 2 years.
No difference, even in octogenarians.
Interesting. And then there's the health study. Huge trial, NEJM, almost 1,500 patients over 50. Again, no difference in revision rates. They found maybe a tiny improvement in function and quality of life with THR, but they called it clinically unimportant.
Clinically unimportant. That's a strong statement.
It is. And then Bhandari's meta-analysis, looking at over 3,000 patients, found similar results again out to 5 years. Revision rates, function, mortality, periprosthetic fracture, dislocation. Pretty much the same for THR versus hemi.
Wow. So the takeaway is,
The takeaway, the aha, maybe, is that for many elderly patients, particularly those with more health issues, a hemiarthroplasty can give really excellent, durable results. And it might be a slightly less complex operation than a full THR.
that's a really important perspective shift based on that newer evidence. Okay, so when you're doing the replacement, whichever type, what about the surgical approach? Is there a preferred one?
Well, the NICE's guidelines tend to lean towards the lateral hard hinge approach. That's the one that splits the gluteus medius.
Okay. What about the posterior approach? That's common too.
It is very common. And it's worth knowing, a systematic review by K1 and colleagues back in 2006 found that dislocation rates were actually pretty comparable between lateral and posterior approaches if you do a meticulous soft tissue repair after the posterior approach.
Ah, so the repair is key for the posterior approach stability.
Exactly. The quality of that closure can really mitigate those traditional concerns about dislocation.
Got it. And the implant itself for these replacements, cemented, uncemented, hybrid, specific designs, what's the thinking there?
Yeah, good question. There's a strong preference now, based on registry data, for using a cemented taper slip stem.
Cemented taper slip.
And if you're doing a THR, then often a hybrid fixation is favored. That means a cemented stem, but an uncemented cup.
And why is that? What's the evidence?
It comes from looking at large registries, like the ones in Norway and Australia, and also reflected in NICE guidelines. They recommend cemented stems with proven femoral stem designs. They even cite examples like the Stryker Exeter stem, which has an ODD 15A rating.
What does that ODP rating mean?
It's a measure of evidence and longevity. 15A means it's been used for 15 years, has top-grade evidence behind it, and less than a 5% revision rate at 10 years. That's, a really high bar for durability.
Definitely.
And the registry data backs this up. Both the Norwegian Hip Fracture Register and the Australian registry show higher reoperation risks, including things like periprosthetic fracture and infection, for uncemented hemiarthroplasty compared to cemented. And for THR in fracture patients, the Aussie registry shows lower revision rates for hybrid THR compared to fully uncemented.
So the data seems pretty strong for cemented stems or hybrid fixation in the fracture setting.
It does seem that way, yeah.
And just briefly, you sometimes hear about different stem philosophies like composite beam versus taper slip. And any quick thoughts on that?
Yeah, both have shown really excellent results in the big European registries. They just tend to fail in slightly different ways, if they do fail.
How so?
Composite beam designs might be a bit more prone to aseptic loosening over the very long term. Taper slip designs, while generally fantastic, might have a slightly higher, though still low, risk of periprosthetic fracture.
Interesting nuance.
It is. And actually, if you look at the NJR, the National Joint Registry, the most popular taper slip design had a tiny survival advantage over others, like 97.9% versus 97.5%. So, practically speaking, both are great, but knowing those subtle differences is useful.
Absolutely. Okay, fantastic overview of the elderly patient. Let's completely switch gears now. Younger patients with femoral neck fractures.
Right, whole different challenge.
It feels like a different ball game, doesn't it?
Wh-
So what does it all mean for a younger person? How do we classify these injuries, and why is that classification so critical?
It is critical. For younger patients, we mainly use Paul's classification.
Yeah.
It's all about the angle of the fracture line relative to the horizontal. Type 1 is less than 30 degrees. Type 2 is between 30 and 50. And type 3 is more than 50 degrees, so more vertical.
And why does that angle matter so much?
Because it directly relates to the amount of shear force across the fracture site. A higher angle, like a Paul 3, means much greater shear forces.
Right. Trying to slide the bone ends past each other.
Exactly. And that fundamentally affects the fracture stability, how you're going to fix it, and honestly, the prognosis too.
Got it. So you have a young patient, maybe a Paul 2 or 3. You need to reduce it. How do you typically approach closed reduction? Any specific maneuvers?
My first step is usually just gentle traction on the limb and some controlled light rotation. Often that's enough.
Okay.
But if it's not reducing easily or it seems particularly unstable, then I'll go to the Ledbetter maneuver.
The Ledbetter.
Yeah.
Can you remind us of the steps?
Sure. There's a handy acronym, FATI-CAR.
FATI-CAR. Yeah.
It stands for flexion, abduction, traction, then with internal rotation. It's a powerful sequence for difficult reductions.
Flexion, abduction, traction, internal rotation. FATI-CAR. Great mnemonic. So you've done your reduction maneuver. How do you know it's good? What are the checks?
Right. You need confirmation. I use 3 key tests. First, the heel palm test.
Heel palm.
Yeah. If the reduction is stable when you rest the patient's heel in your palm, the leg shouldn't spontaneously flop back into external rotation.
Okay, makes sense. What else?
Second, Lowell's alignment theory. On your AP and lateral x-rays, you look at the outline of where the femoral head and neck join. It should form a smooth S or a reverse S shape.
S or reverse S?
If it looks like a C, that means there's still some angulation. It's not quite right.
Got it. C is bad. And the third?
Third is revisiting Gardner's alignment index, like we talked about earlier. That angle needs to be 155 to 180 on the AP and 180 perfectly straight on the lateral.
Okay. Heel palm, Lowell's S-curve, Gardner's index.
Got it. Those three give you pretty good confidence.
But what if closed reduction just doesn't work? What's your go-to approach for an open reduction in a young patient?
For open reduction, the standard is often the anterior Smith-Peterson approach. It gives good access.
Smith-Pete. Okay. Any alternatives?
Well, some surgeons might consider Watson's anterolateral approach. The potential advantage there is maybe doing it through a single incision if you're dealing with other things around the hip at the same time.
Okay. And implants for these young patients. You're trying to save the head, obviously. What are the options? Is one better than others?
Head preservation is absolutely the goal. So options usually include maybe 3 cancellous screws put in an inverted V shape, or a dynamic hip screw, the DHS, or one of the newer femoral neck systems, FNS, which gives more angular stability.
Screws, DHS, or FNS. How do you choose?
It often comes down to the fracture pattern again, especially that Paul angle. Remember that Lippert study?
Yeah, the 19% non-union with screws versus 8% with fixed angle in Paul 3s.
Exactly. Even though it wasn't statistically significant in that study, it really points towards fixed angle devices like a DHS or FNS being potentially biomechanically better for those very vertical, unstable fractures in young people.
Right, better resistance to shear.
Precisely.
You also mentioned a specific Paul screw configuration. Can you explain that a bit more? How does that work?
Yeah, the Paul screw, sometimes called a trochanteric neck screw. It's a specific technique. It's a lag screw, but instead of coming from the side, it goes in from the greater trochanter itself.
From the top?
Kind of, yeah. And it's aimed to pass perpendicular to the fracture line, right into the inferomedial part of the femoral head.
Perpendicular to the fracture. Why is that important?
Because that orientation directly counteracts the shear forces. It turns shear into compression right at the fracture. And biomechanical studies have actually shown this configuration can be up to 70% stiffer than standard parallel screws.
70% stiffer. Wow. That's significant.
It's a big difference, especially when you're aiming for rock-solid fixation in a young person.
What about adding things like a medial plate or doing a capsulotomy? Are those common?
A medial plate can be used, but it's often more as a reduction tool like a buttress to hold the reduction while you put the main screws or DHS in, not usually the primary fixation itself in these cases.
Okay, a reduction aid and capsulotomy.
Capsulotomy.
Well, there's no real consensus on that. The theory is sound, right? You open the capsule to release the hematoma pressure, the tamponade effect, which might improve blood flow to the head and reduce AVN risk.
Makes sense theoretically.
But the clinical evidence is still pretty equivocal. We don't have definitive proof that doing it routinely improves outcomes.
Right. Okay. Now, the big question for young patients, timing. Do you rush them to the OR? Is time really the enemy when it comes to AVN risk in this group?
This is such a critical point, and there's often misunderstanding. The literature does not show a clear consensus that rushing to theater within, say, 6 or 12 hours definitively prevents AVN in young patients.
Really? So it's not like the elderly where faster is clearly better for mortality. It seems different for AVN risk in the young. My priority would be getting the right team, the lead trauma surgeon available, and planning it properly for the next day's elective list, rather than a rushed middle-of-the-night case potentially.
So what does the evidence say?
Well, studies like Upadhyay's RCT found no difference in AVN rates whether surgery was done before or after 48 hours. Martin Parker's meta-analysis in 2005 found no difference comparing less than 12 hours versus more than 12 hours.
So what is the most important factor for outcome then?
The quality of the reduction. That's the real predictor. An anatomical, perfect reduction is paramount for preserving that femoral head, much more so than just the clock on the wall.
Quality of reduction trumps timing for AVN risk in the young. That's a key takeaway.
Absolutely.
So if timing isn't the main prognostic factor, what are the things that predict a poor outcome in young femoral neck fractures? What should residents really watch out for?
Good question. Several things. Duckworth and colleagues, in JDJS 2011 pointed to patient comorbidities, things like pre-existing kidney, liver, or lung disease. Also, chronic alcohol use was a factor.
Okay, comorbidities and alcohol.
And then Upadhyay and colleagues emphasized fracture characteristics, comminution, how fragmented the bone is, and, as we just hammered home, the quality of the reduction achieved.
Comminution and reduction quality. Makes sense.
Those are really key factors influencing the long-term result.
And overall, what's the risk of AVN we're talking about in young patients? And any tips for screw placement to avoid problems?
Upadhyay's work suggested an overall AVN incidence around 16.3%. So it's definitely a significant risk we're trying to avoid.
16%, okay.
And for screw placement, the key principles are stay at least 5 millimeters away from the subchondral bone to protect the joint surface. And ideally, keep the screws above the level of the lesser trochanter to avoid creating a stress riser lower down the femur.
5 millimeter from subchondral bone, above the lesser troch.
Wow.
Got it. Okay, let's move to another tough scenario. A patient comes back maybe months or years after their initial fixation, and they've developed a non-union or AVN.
Yeah, the salvage situation. Always challenging.
What's the actual likelihood of these complications happening after fixation, and how do you start evaluating them?
Unfortunately, it's not rare. That meta-analysis by Slobodin and Bhandari in 2015 found an overall reoperation rate after fixation of about 18%.
Nearly 1 in 5 need more surgery.
Yeah, and specifically, non-union occurred in about 9% of cases and AVN in about 14%.
Okay.
Now, it's important to know, with AVN, most cases are actually segmental, just a part of the head, and often don't collapse right away.
Well,
Only about 20% of those AVN cases actually end up needing further intervention.
and when they do need intervention for AVN?
It's usually a total hip replacement. That was highlighted by Nikolopoulos and colleagues in the journal Umjri.
Okay. So how do you evaluate these patients when they present?
You definitely need good imaging. I'd get a CT scan to really see the bone detail, assess the non-union gap if there is one, and an MRI is crucial to look for AVN and see how extensive it is.
CT for bone, MRI for AVN. Makes sense. And if you confirm a non-union, let's say without significant AVN, what are the salvage surgery options?
Right. First, you absolutely have to rule out underlying infection. That's step one.
Always rule out infection.
Always. And confirm there isn't significant symptomatic AVN that would just doom a refixation. If you're clear on those fronts, you're weighing refixation versus converting to a replacement.
And for refixation, what techniques are there?
Several options. You could use an angle blade plate that gives really solid purchase in the bone. Or you could perform a valgus intertrochanteric osteotomy.
A valgus osteotomy, how does that help?
It's clever biomechanically. You cut the bone below the fracture and angle it into valgus. This changes the forces across the non-union site, turning those bad shearing forces into helpful compressive forces, which encourages healing.
Okay, changing the mechanics.
Exactly. And sometimes, for really tough cases, you might consider what's called the triple attack.
Triple attack.
Yeah.
It sounds serious.
It is. It combines bone grafting for biology, the valgus osteotomy for mechanics, and a strong fixed angle plate for stability. Maximal effort to get it to heal.
Bone graft, valgus osteotomy, fixed angle plate. The triple attack. Got it. Okay, one last complex scenario before we wrap up. Neck and shaft fracture in the same femur, ipsilateral neck and shaft.
Yeah, that's a tough combination.
That sounds incredibly challenging to fix. What's the thinking on implants? One long implant, two separate ones?
Yeah, there's actually no definite consensus from strong evidence whether a single long implant, like a reconstruction nail, is better than using two separate implants, say screws or a DHS for the neck and a standard nail for the shaft.
No consensus.
Studies haven't shown a clear difference in AVN or non-union rates between the two strategies. However, Bhandari did a systematic review back in 2003. It found some, albeit weak, evidence, mainly from case series, suggesting that using dual implants might lead to fewer reoperations down the line.
Fewer reoperations with two implants. Okay. So what's the overall fixation strategy or priority then?
The absolute #1 priority is the neck fracture.
Right.
You must get an anatomical reduction of the neck, perfect alignment, and then you need absolute stability fixation for the neck. Usually that means using a dynamic hip screw, a DHS.
Anatomical reduction, absolute stability for the neck.
First and foremost. Then, for the shaft fracture, the principle is different. You want relative stability. Allow a bit of controlled motion to encourage callus formation, and that's typically achieved with a retrograde femoral nail.
Absolute stability neck, relative stability shaft. Got it. Can you walk us through the steps?
Sure. So first, focus on the neck, patient usually on a traction table. Drape the groin so you can access it if needed. meticulous close reduction attempt, but have a really low threshold to open reduce the neck if you need to, usually via a Smith-Peterson approach to get it perfect.
Low threshold for open reduction of the neck.
Okay. Once it's anatomically reduced, you fix the neck with a DHS coming in through a separate lateral incision. Put in your proximal screws, maybe leave the 2 distal screw holes empty for now.
Okay, neck fixed. Then the shaft.
Then you often transfer the patient to a supine position on a radiolucent table. Now you address the shaft fracture. Insert a retrograde nail, making sure it overlaps nicely with the proximal DHS construct.
Retrograde nail overlapping the DHS.
Yeah. And then the final step is to go back and insert those remaining 2 distal screws into the DHS plate, locking everything together. This sequence prioritizes the neck, but addresses both fractures with the appropriate stability principle.
That's a really clear sequence for a complex problem. Wow, this has been quite the journey.
It really has.
We've gone all the way from the basic anatomy, Ward's triangle, right through managing elderly fractures timing, fixation versus replacement, hemi versus THR, then into the specifics for younger patients, classification, reduction, fixation choices, the AVN debate, and even tackled non-union and those complex combined injuries.
Yeah, covered a lot of ground.
It feels like a great mix of the core knowledge, the latest evidence, and those real-world clinical scenarios, and all drawn from those fantastic ortho-made simple notes on mokyingren.sg.
Exactly. And what's really striking, I think, is seeing how all these different pieces, the anatomy, the biomechanics, the big trials, the registry data, how they all have to come together when you're making a decision for an individual patient.
It's not just about knowing the facts, is it?
Not at all. It's about understanding them, synthesizing them, and applying them critically. Hopefully, this deep dive helps encourage that kind of thinking.
Absolutely. Well, thank you so much for joining us on this deep dive into femoral neck fractures. Again, all based on the ortho-made simple notes from mokyingren.sg. We really hope this gives you, our listeners, a clearer, more confident handle on this really important topic.
And maybe just a final thought to leave you with as you prepare for exams or your own practice. What really stands out to you now about that complex interplay, between the patient factors, the surgical timing, the implant choices? How do you see them influencing outcomes in femoral neck fracture? Something to mull over. Keep digging deeper.